Hello and welcome to the Community Pharmacy Halton St Helens and Knowsley LPC Pharmacy First webinar. The webinar today will cover a summary of the service requirements, including local implementation, an overview of the clinical pathways and PGDs, with a focus on the UTI, otitis media and sore throat, preparing to provide the service, and finally learning and development requirements and resources. The Pharmacy First service is a new advanced service for community pharmacy starting today, the 31st of January, and replacing the community pharmacy consultation service. It's one of the most important services to be launched for community pharmacy. The NHS and the Department of Health have invested new money into this service and have put their trust in community pharmacy to deliver to a high standard. The service will consist of three parts: the new clinical pathway element, which will allow walk-in consultations for those patients who meet the gateway, and the two elements of CPCS, which remain unchanged. Moving on to the 7 clinical conditions, this slide shows the conditions included within the pathways and, more importantly, the age range of patients they apply to. We expect all year round that the highest number of referrals will be for UTIs, followed seasonally by sore throat and possibly sinusitis. Smaller volume of referrals is expected for the others, with a summer peak of infected insect bites. Any pharmacy who opts in to provide the service must be able to deliver all three elements. There's no pick and mix option. Patients can only walk in for the clinical pathway element of the service, with GPs and 111 continuing to make referrals for minor illness and urgent medicine supply, which fall outside of the pathways. Remote consultations for all elements are permitted, with some differences depending on if it is a minor illness or clinical pathway referral. Remote clinical pathway consultations are only permitted via high-quality video link, with the exception of otitis media, which must be delivered in person due to the requirement to examine the ears. This means that distance selling pharmacies can only deliver 6 out of the 7 pathways. They must deliver all consultations remotely via a video link due to the self-care element of the service, and self-care being an essential service which cannot be delivered on the pharmacy premises from a DSP. There are no changes to the pharmacy PCS elements of the service. Referrals are still required and telephone consultations are still possible where clinically appropriate. So to give a couple of examples, constipation as a walk-in can't be pharmacy first, but could be referred by a GP practice and could be completed over the phone if appropriate. A UTI can be a referral or a walk-in, but if it needs to be remote, it must be via a video link. We'd like to highlight some of the local information that you may find useful. The Care at the Chemist service will continue as before, and this service can support all elements of Pharmacy First if a patient is eligible for a Care at the Chemist consultation. If the patient doesn't meet gateway for a clinical pathway or has been referred for a minor illness, it may be appropriate to supply an OTC medicine via Care at the Chemist. Equally, if a patient does meet gateway and is supplied a medicine under a pathway and would benefit from an OTC medicine as well, it could be provided under Care at the Chemist if appropriate. Referrals from GPs will arrive into pharmacy in the usual way, and for most pharmacies that will be via Pharm Outcomes. One change to note is that GPs should now be recommending that patients contact the pharmacy within 30 minutes, where previously patients have been advised that they will be contacted by the pharmacy. So it's really important that your staff know this and are able to identify any patients who may phone or walk in to the pharmacy following a referral. If you receive a referral but the patient does not contact the pharmacy, you must make reasonable attempts to contact the patient as soon as possible. If no contact has been made with the patient before the next working day, close the referral via Pharm Outcomes or your IT system and mark it as no supply made, patient not contactable. Finally, on local service information, a new version of Annex C from CPCS is currently being developed and will be uploaded to Pharm Outcomes soon. I will now hand over to my colleague, Helen.
Okay, so Lou has talked about the clinical pathway consultations. So we've got the service specification, 7 clinical pathways have been developed. There are 23 PGDs and 1 clinical protocol. It's important to note that the clinical pathways contain 1 or more gateway points, and you can actually see that gateway point highlighted in yellow to the side on the slide. So for a patient to be eligible to receive a clinical pathways consultation, a gateway point must be passed in order for that to actually occur. If the gateway point hasn't been passed and it's a walk-in, then it doesn't count because it's part of the essential services. But I'll demonstrate that further along. So next slide, please, Lou. Okay, so I mentioned before that there are 23 PGDs and 1 protocol, and that's an awful lot to take in. The purpose of this slide here is just to highlight that actually there's quite a lot of commonality between some of the medication that is to be supplied by the pharmacists. So for example, if you look across, clarithromycin covers 5 of the PGDs and protocols. Erythromycin is the same. So once you're familiar with those PGDs, you're actually becoming familiar across a range of the different clinical conditions. But what I would say is it's important that you ensure that you understand the differences for each clinical condition, because they include, those inclusion criteria are the bits that are most important. In saying that, as has been mentioned, we expect that UTIs and sore throats are likely to be the most commonly referred and walked in conditions. So in that instance, you've got UTIs have got one PGD, sore throats have got 3 PGDs. Next slide, please. Okay, so this is a high-level service overview. And what you can see here is the urgent med referrals down the left-hand side. That's exactly the same as it was before. There's no changes there. Then you've got referrals that will come through from the GP practice. Minor illness referrals will carry on to some extent as before. So you'll get a minor illness referral and it may just flow through to a minor illness consultation. So for example, someone came in with constipation and it was referred as a minor illness, that would follow through as before. However, you might get a child who's referred for rash as a minor illness, and actually you might identify that could be impetigo. So you look at the impetigo clinical pathway, and if the gateway is met, then it moves across to the right to go into the clinical pathway referral process. Then you've got referrals that may come in for one of the 7 common conditions, and actually, if the gateway criteria is met, then they will pass through and you will carry out a clinical pathway consultation and you'll record that. But if the gateway isn't met, that's when it might actually move across and you would record it as a minor illness and you would complete that referral as if it was a minor illness and you complete a minor illness consultation. So that's referrals that have been covered. Then we move to the patient presenting to the pharmacy for walk-ins. And as has previously been mentioned, this element is only for the 7 common conditions. It's not for minor illness, because minor illness walk-ins are covered under the essential service. So if somebody walks in and they think that they might have, for example, a UTI, if the gateway criteria is not met, then that is self-care. That's self-care via the essential service. If the gateway criteria is met, you can record that consultation as part of the clinical pathways consultations, and you will be paid for it. So actually, it's really important that that the staff that you have, on the counter, meeting the patients as they come in, are able to recognise these 7 common conditions so that they can refer them on to the pharmacist as appropriate. A more detailed service pathway diagram can be found in Annex A of the service spec, and actually that's really quite useful at providing a bit more detail about what happens. Okay, so just accompanying this slide, I'm going to cover how the payments work. So if you consider referrals, you're always going to be paid for the pharmacy first referral if it's completed fully, and you don't refer it on to another pharmacy. If you identify the patient in the pharmacy, you only get paid for a clinical consultation, a clinical pathway consultation, if the gateway point is met and crossed and you carry out the clinical pathway consultation. Only clinical pathway consultations that cross the gateway point and are fully completed count towards your monthly minimum number of consultations for the block payment. And I'll come on to that in a minute. If a clinical pathway referral goes to supply and the patient pays for their medication normally, then collect the prescription charge as appropriate. Next slide, please. Okay, so for funding, you're going to be paid an initial fixed payment of £2,000 if you signed up to the service by the 30th of January. But it's important to note that you need to have completed 5 clinical pathway consultations by the end of March in order to keep that £2,000. There's going to be a £15 fee per completed consultation across the whole of the service. So that applies to CPCS consultations and did so from the 1st of January 2024. I mentioned a minute ago about block payments. So these block payments, there's a monthly fixed payment of £1,000 where the pharmacy meets a minimum number of clinical pathway consultations. And you can see those down the side, initially starting low. 1 consultation needs to be completed in February, but eventually that ramps up to 30 by October onwards. And I think that's where the referrals from the GP practices will come in, and also the awareness from members of the public around the service. From April 2020, an initial cap of 3,000 consultations per month per pharmacy is going to be put in place. And from October 2024, that new cap is going to be reviewed. Next slide, please. Okay, so this focuses very much on the clinical pathways and PGD element. So we've got your minor illness consultations will carry on as they did before, self-care, advice, OTC sale, possible care at the chemist, and referral on to another healthcare practitioner if appropriate. The clinical pathways are not massively different, but they do include the supply of a restricted set of medicines. So when you're managing those 7 common infections, you'll offer self-care. If they don't meet the gateway criteria, or even if in some instances they do pass through the gateway criteria, self-care, OTC supply, and maybe supply via care at the chemist can be appropriate. So, for example, someone with a sore throat may not need antibiotics, but providing pain relief to help them manage that condition is a useful way of dealing with that condition, and it's totally appropriate. Safety netting advice is the other element, and then only if appropriate, you would supply a restricted set of medicines. Within the clinical pathways, there's been rigorous oversight by the Antimicrobial Resistance Board to ensure adherence to antimicrobial best practice guidelines. So if we move on to the next slide, please. So if we're talking about monitoring and surveillance, including antimicrobial resistance, NHS England are going to be closely monitoring the service post-launch to check the data. They're looking to check for instances of supply of medication for excluded patient groups, maybe red flags, and also inappropriate or excessive supply of medication, including antibiotics. So previously for CPCS, that data wasn't looked at in any particular detail, but for Pharmacy First, the data is going to be looked at, and that's so that they can take any mitigating action that they need to as quickly as possible, because they want the service to work well. They will have the ability to compare GP and pharmacy antibiotic supply data, so that's something to be aware of. But if you adhere to the pathways and the PGDs, you're only going to be supplying medication where clinically appropriate for the patient, and therefore the impact of the service in relation to antimicrobial resistance will be appropriately managed. And just to say that there will be an evaluation of Pharmacy First services looking at the implications for antimicrobial resistance. Okay, next slide, please. Okay, so I've mentioned there's 23 PGDs and 1 protocol. It's really important that you read and sign the final versions of the PGDs, because the draft ones that were published on the 1st of December weren't signed by NHS England, so they don't provide the authorisation that you need to supply medicines at the NHS expense under this service. The final PGDs and protocols are now published on the NHS website. It's also worth mentioning that CPE have recently put on their website a Word version of the authorization sheet, which allows the pharmacists and the authorizing managers to sign off in one place. So that's really useful to know. I think we're still possibly waiting for the single authorization sheet for the pharmacists so that they can sign off in one place. Next slide, please. Okay, so clinical record keeping, this is a really important element of the service. So your clinical IT system is going to send the message containing a summary of the consultation to the patient's general practice. And that record is now going to uplift into the patient's record. So it's going to be visible to all the clinicians that actually deal with that patient, that access the GP record. It's really important, therefore, that your consultation notes are comprehensive and that they're professional. It's important to include what happened, information and findings, any justification for decisions that you've made, whether that be to supply a medication, an antibiotic, or actually that you didn't supply on that instance. Include any written or verbal information that you've given to the person, and really key, include any safety netting information that you have provided to the patient, because that covers you in terms of, I then advised the patient that if the condition worsened, what to do. If the symptoms didn't improve within X number of days, what to do. And that's really, really important, because that covers you as a clinician, and it's something that the GPs will often record. Okay, so these records are going to be, could be visible to the patient depending on the IT arrangements that that individual has. So I think it's really important that you're aware of the choices of language that you use when you're recording your consultation. I think it's good to assume that the patient at some point could read what you've written in the consultation. Previously, they wouldn't have been able to record what you'd written in Pharm Outcomes because that would have been held on your IT system. This is going to be on the GP system, and more patients are getting access to their clinical record. So please ensure you record what's appropriate. Also consider that GP patient records can be requested and reviewed if there's ever any litigation by the patient or for coroner's court, and therefore your record will be on the system and visible, and therefore it's important that it is clear to anybody who needs to look at that record to understand what happened within your clinical consultation. We recommend that you write the consultations as you go. The Pharm Outcomes, if you use Pharm Outcomes, we know some pharmacies don't. If you use the Pharm Outcomes system, it actually really helps to work you through that consultation. It will help to prompt you with a number of things like the exclusions, which is really helpful. So it's very useful to access that IT system as you're doing the consultation so you don't miss any key information. But the specification actually requires that the consultation is recorded within 24 hours. If you're thinking about your clinical record recording skills and your history taking skills, if you want to brush up on those skills, CPPE have an essential skills for pharmacy first, which also includes practicing recording a consultation. But I have also got a list here of things that you might, that are really recommended in terms of recording a clinical consultation. So think about the presenting complaint. What's happening with the patient? Look at the history of the presenting complaint. Past medical history is going to be important. You're going to need, for the purposes of the PGD, you're going to need to understand what other clinical conditions that patient has. That's going to be important. You're going to need to think about the medication that the patient is already taking, and you may need to access the National Care Record in order to do that. Allergies are key because many of the supplies and for the 7 clinical pathways have antibiotics. There may be an allergy to that antibiotic, but there may be allergies to other medications that you might be recommending as part of over-the-counter or care at the chemist. Think about social, holiday and travel. That's also some of the things that are included within the PGDs. Any hospital admissions, vaccination history that might be relevant, any other medication that they may be taking that isn't prescribed, are they pregnant or breastfeeding, and anything else that they consider to be relevant. There's some examples of what you would expect to consider when carrying out a clinical consultation. But again, it's about understanding the full comprehensive list of things that you need to do in order to carry out a clinical comprehensive consultation. Next slide, please. Okay, so now I'm going to go into, and I'm just going to do one pathway, and it's the UTI. Okay, so the top of the pathway has the inclusion and the exclusion criteria, so that's kind of key. So that's really one of the first things that you need to be thinking about when this individual is referred through via the GP practice or when they walk in, because the walk-in patients won't know what the inclusion and exclusion criteria is and whether you can treat them. And likewise for the GP practices, they will be following some guidelines with regard to the inclusions and exclusions criteria, but they won't necessarily know all of those. And sometimes some patients may be referred that don't meet the inclusion or exclusion criteria. The first thing you need to do is rule out a serious illness. And you can consider calculating the News 2 score if you think somebody is appearing to be really, really unwell. After that, you're checking for signs and symptoms of pyelonephritis that are listed in that grey box. If you were to identify signs and symptoms of pyelonephritis, then you would send them for an urgent same-day referral to the general practice or relevant out-of-hours services. If you've ruled out pyelonephritis, you then move on to the types of conditions that cause urinary symptoms that aren't necessarily related to your urinary tract infection. So, for example, vaginal discharge, etc. So you would work through all of the elements within that grey box. If they answer yes to any of those elements, then you're going to be referring them onwards. If they answer no, then they've hit and passed a gateway point, and that's when you move through the gateway point. Next slide, please. Once they've moved through the gateway point, you're then looking at whether they have any of the sort of major symptoms associated with diagnosing a UTI. So that's dysuria, burning pain when passing urine, new nocturia, needing to pass urine in the night, cloudy urine to the naked eye, and it is recommended that if the individual can supply and show you their urine, actually that's really useful at being able to identify cloudy urine. So you need to think about how you might do that if you're doing a remote consultation. So don't be surprised if someone brings in cloudy urine or brings in a sample of urine, and if you're asking the patient to come in, then you may want to see if they can give you if they can bring in a pot of urine so that you can assess whether you think it's cloudy or not. If there's no symptoms, then a UTI is less likely and you move on to self-care. If they've got one symptom, the UTI is equally likely to another diagnosis, and the pathway points you to refer onwards. If there are 2 or 3 symptoms, that's when you're going to be looking to moving into shared decision approach. And with that shared decision approach, you can use the target UTI information that's available. If there are mild symptoms, then the pathway indicates that you would look at self-care, but advise the patient to return if there's no improvement. In patients to moderate to severe symptoms, that's when you would be recommended to supply 3 days of nitrofurantoin, subject to PGD inclusion-exclusion criteria. Think about allergies and whether you can still supply, and to provide safety netting and self-care advice. For all patients, you need to advise them if the symptoms worsen or significantly deteriorate, that they need to go back and they need to go for referral through to their GP practice. And for every patient, offer self-care safety netting advice. Okay. What I would say is CPE have now got the videos available on their website for all 7 of the clinical pathways, and I really recommend that you go and have a look at each one of those clinical pathways. Okay, next slide, please. Okay, so I'm not going to go into this in massive detail, but this is essentially the inclusion and exclusion criteria for a UTI. So you're looking at female, non-pregnant, age between 16 to 64 years old, and of course you need patient consent. And then you can see lower down in the slide the key exclusions for the service. But it's important that you are aware that there are other exclusions that do apply linked to the PGDs. And so therefore you need to be aware of the content of your PGDs as you work through them, so that you can spot those individuals who are excluded due to PGD exclusions as well. Next slide, please. So just to cover the hints and tips for UTIs, because this is new. There's no need to dip urine, but the pathway does include a visual inspection for cloudy urine if practicable. And what you can see here is just in the happy and sad faces and those pots of urine, You can't see through the pot of urine with a sad face, but actually you've got a nice happy face for the clear urine when there's no UTI. So the sad face is indicative of cloudy urine and a UTI infection. Use the pathway aid to decision making, the target leaflet to explain where a supply isn't made. Ensure that counter staff can triage and refer patients to the pharmacist. Don't be afraid to supply antibiotics if the symptoms are mild. So don't be afraid not to supply antibiotics if the symptoms are mild, because the patient can represent if necessary. If the patient is unsure if they're pregnant, then you need to be thinking about them getting a pregnancy test before you actually move forward. That's really important. Provide general self-care guidance irrespective of antibiotic treatment. So, for example, increasing fluids, reduce caffeine and alcohol, pain relief, and wearing of loose cotton clothing. And know where to refer the patient to if there needs to be an onward referral. Okay, next slide, please. Okay, so we're moving directly into sore throats now. And I'm not going to go through the pathway for that one. So, sore throats, hints and tips. If you suspect epiglottitis, the pathway recommends that you don't specifically look down the person's throat. Our GP on the night suggested that epiglottitis is particularly rare. But what he did say is it's key not to be putting tongue depressors on someone's tongue and looking down the throat if you really do think that there is epiglottitis present. So the use of tongue depressors really is not recommended in that instance. However, you are going to need to look down the throat to exclude signs and symptoms of scarlet fever and quinsy. And you may need to confirm the signs of purulence and severely inflamed tonsils. Use the target leaflet aid to aid decision making. Even a fever pain score of 4 doesn't definitely mean that it's a bacterial infection. And antibiotics don't reduce the length of the illness by very long. So in the clinical pathway for sore throats, you'll be looking at fever pain and a fever pain score as a mechanism by which you will assess the patient. So you need to understand how that all fits. Ensure counter staff are upskilled in order to refer the patient when needed. If you get a fever pain score of 2 to 3, then you'd be looking at asking them to return in 2 to 3 days if there's no improvement for reassessment to hit the gateway point, to see if they hit the gateway point. So follow that clinical pathway according to the fever pain scores that the individual receives. Provide self-care advice, ice lollies, cold drinks, pain relief, and avoidance of hot drinks if they exacerbate pain and rough foods. But I would recommend, as I said before, have a look at the videos on CPE that go through the clinical consultation pathways because they are very good. Next slide, please. And we're now moving into preparing to provide the service. So I'm going to hand over to David.
Thank you, Helen. So Helen has actually covered quite a number of the points, but I think it's really, really important to make sure that you've read the service specification and have printed off the clinical pathways. If you haven't already, download and read all the PGDs and the clinical protocols. Ideally, you want to keep a folder in the consultation room with the pathways, with the PGDs, and also print off some target leaflets for staff to refer to and to provide to patients. If you've not already done so, please sign up on MYS and also start to update your SOP or your existing CPCS SOP. Next slide, please. So it's important to have an otoscope in the pharmacy and disposable tips. What you do need to do is, if you haven't already ordered an otoscope, you have until April the 1st to have an otoscope in the pharmacy as part of the service. If you're using Farm Outcomes currently for recording of GP CPCS, then the transfer to the new Pharmacy First module will be seamless. We don't have any information in terms of other IT providers. If you haven't already done so, go to the homepage of Farm Outcomes where you log on, and there is a video which is available for you to look at. It's a very comprehensive video, and it shows you how to record the consultations, all the red flags, and how to transfer a patient to another pharmacy should you need so. It's also important as well in terms of video linked consultations. So this is a key element of the service. So you need to work out which software you're going to use for these remote consultations, and have a practice. Get used to using the software and make sure that all your staff in the pharmacy know how to access the software to support the locums when you're on annual leave. Next slide, please. Register for and access Service Finder to facilitate onward referrals, and just ensure members of the pharmacy team are able to do this. And again, if you look at the Farm Outcomes video, then there's a whole section there on how to do this. This is all about communicating to your pharmacy team, the rest of your team in the pharmacy. So make sure you've got the CPE briefing and virtual outcomes briefing. Next slide, please. If you're a pharmacy where you have several pharmacists working with you, make sure that you've got a training plan. If you go to CPPE self-assessment, there are tools available to do this. What's really, really important with this service going forward is about communicating to your local GP practice. Go and meet with them and work out how many referrals you can manage per day or per week. And while you're there, have a conversation with the practice manager around escalation of patients back to the practice and what's the most efficient way of doing this. And they often have a backdoor telephone number, and just ask for that backdoor telephone number. Patients will be asked to phone the pharmacy. So again, it's important to brief the staff in terms of picking up those phone calls. You may want to put in an additional phone line. That might be useful. So it's all about working out how you're going to manage this. Next slide, please. Helen's talked about in terms of clinical note taking. So you will have access to the National Care Record Service, which is the successor to the Summary Care Records, and NHS Shared Mailbox. So what's also important as well is to make sure that your consultation room is fit for purpose. Clean it up, tidy it up, get rid of all those boxes of Ensure and other bits and bobs that are there. And just make sure that it's looking more like a proper consultation room, that the door closes, etc. Also consider things like clinical waste. So you're going to have to put in otoscope tips. You may have urine that bring samples that patients bring in. So just make sure that you're well prepared for this service. Next slide, please. Okay, so booking locums, just make sure that they know that they'll be expected to deliver Pharmacy First from the 31st of January. There's virtual outcomes to support team training so that they recognise GP referrals and walk-ins. Are your team able to give clear waiting times to see the pharmacist or collecting prescriptions? Do you have enough seating in the pharmacy for patients who are waiting to see the pharmacist? And bear in mind that consultations for the clinical conditions will need to swap from telephone to video if the patient phones the pharmacy. So it's all about managing your workflow, and just, if patients have to wait 10, 15 minutes, then that's what they will need to do. And I'll now hand over to Louise. Louise, do you want to
David, there
pick
was a
this up?
couple.
Yeah.
There was a couple of slides there, I think, David, of yours still to work
Oh,
through.
is that right? Okay, sorry. So as I mentioned, in terms of managing the workflow and queues to help reduce waiting times. So please bear in mind, particularly as we get towards October, when there'll be a lot more referrals and patients coming into the pharmacy. So it's important to think about how you're going to use the dispensing team to make sure that, consultations are done. Use your ACT, use other people within the team. Check farm outcomes on a regular basis and NHS Mail, not just once during the morning and once during the hour. Check every hour. And just make sure you've got a sufficient equipment in the pharmacy with otoscope tips, disposable tongue depressors, thermometers, tips, and video software. And have a BP machine as well. That would be really useful to have there. Next slide, please. Okay, so in terms of business continuity, if you've got staff sickness, unplanned closure, don't be afraid to contact your local GP practice. If you need to temporarily withdraw from the service, it's better to do that than not deliver. Contact your local GP practice if you've got some real issues. Speak to them so that they understand where you're up to, so that they can send referrals to another pharmacy. Think about red flags. So if you need to calculate news to you score, then you can use things like MD Calc on a phone or access via farm outcomes. As Helen mentioned, the consultation will drop into the patient's GP record. It's essential that this information is recorded in a professional manner. If an action is required by the GP practice, don't put that message in the consultation. Contact the GPs directly. Next slide. And finally, resources to help you get ready. If you go through to the CPE website, there is pages and pages of information, documents, template letters, briefing letters. There's going to be a CPS toolkit, which is being updated to cover the new service. CPE summary briefing for pharmacy team members, and also go and look at the farm outcomes video on how to record a consultation. So the general message is there's a lot of information out there. Just make sure that everybody in your team is involved in delivering this service. And I think that's my final slide. Thank you, Louise.
Thank you, David, and some really useful hints and tips there for everybody. I hope you found that section helpful. I just want to recap on some of the learning and development requirements for pharmacy. I know some of it's already been mentioned before, but I think it's helpful to summarise some of that into a couple of final slides. So the CPE website is probably your go-to starting point. There's loads of resource out there. Everybody's learning style is different, and we've linked some key resources in a training summary which we've sent out to pharmacies via our webpage, our deadline tracker, and our newsletter. So please do have a look at that document because it's got some really useful links in there to different training options. But like I said, CPPE is a good starting point. We've developed the self-assessment framework and the action plan that David and Helen have already mentioned, and that will really help you understand your knowledge gaps and what it is that you might need to do. Towards the bottom of the CPPE gateway page, there's a resource drop-down box, which is a range of e-learning materials and videos covering the pathways and some other essential skills. Some other key resources that we're aware of are CliniSkills. They were commissioned nationally to provide some training to community pharmacy face-to-face. Those webinars are finished for now, but they are looking to put on some more. So if we find out any information, we'll send that across to you via our newsletters. However, they do have a range of free e-learning modules on their website as well. So it's really worth having a look at what's available from CliniSkills. CPE have done a couple of webinars too, more in the practical aspects of delivering the service and what's out there. So they've got a Getting Started webinar, which was run in December, and a Getting Ready for Launch webinar earlier this month. Both really worth watching, and they can be accessed from the CPE website. From a dermatology point of view, one of our local GPs in Cheshire and Mersey has recorded a video for us, and we hope to get that uploaded to the LPC website for you soon to watch, and that'll be really helpful. I think some really good, useful information around dermatology in that. And finally, Agilio provided some 30-minute e-learning modules, one for each clinical pathway, and these have been written by the authors of NICE CKS, so really on the mark there with the clinical information and the red flags that you might need to be aware of. And I'll hand over to Helen. Thank you.
Thanks, Louise. Okay, so I'm just going to talk a little bit about some of the information that Alder Hey have shared with us. So they've shared something called the Cheshire and Merseyside Big Six Guidance, and that's available on our LPC website at the moment. And it's there to support the management of the most common conditions that a child can present with to A&E or urgent care. What they've indicated is that the News 2 score isn't necessarily as applicable in children, but they have identified a Pew's score that can be used instead, and that has different age ranges and different charts that exist. Look, I've had a little look at that information, and actually I found that slightly, quite difficult to get to grips with. What I would say is, in the knowledge that the News 2 score isn't necessarily as applicable, the Big Six Guidance has some really, really useful information in there to help you to identify a really sick child. So it covers a reasonably well child, a child that's, is a bit poorly, and then you've got your really sick child. And it's the really sick children that it can be really useful for, to help you to identify that those are the children that you need to refer on very, very quickly. So I can't recommend enough the Big Six Guidance. It's a very useful aid. The LPCs have been linking in with Alder Hey, and we are expecting some other resources which are listed there. So things like spotting a sick child. There's a blog on paediatric assessment, the paediatric assessment triangle for triage, pain scores, how to assess pain in a child because they can often present differently, airways difficulty guidance, a useful safety netting script, including what to do if symptoms deteriorate, and short videos looking at throat and looking in ears, sort of what's wax, things like that. So some useful information, so look out for that. Once it's available, we'll be putting the details in our LPC newsletter, and then it'll also go on our website as well. Next slide, please. So this slide basically just illustrates the most common conditions that children present to urgent care with. So you're looking at sepsis, fever, respiratory, gastroenteritis, head injury, and abdominal pain. So they're the things that are covered within the Big Six Guidance. But as I say, it has some really useful information. And just as an example, we've got here a slide at the bottom of the slide. It shows the normal vital signs in children. And what's actually really quite surprising in some respects is that, for example, the heart rate in an under one, a normal heart rate is 110 to 100 beats per minute. For a 1 to 2 year old, it can be anything from 90 to 150 beats per minute. So kiddies' heart rates are far faster than the average adult. And I think it's really important that you understand that. And also in terms of their respiratory rate as well, it's understanding what's normal. So that's just an illustration of the type of information that you'll get in the Big Six Guidance. Next slide, please. Okay, so David's mentioned virtual outcomes. It's a free resource. It's been commissioned and funded by the ICB, so we would encourage you to use it because it is a great resource, and the more it gets used, the more it demonstrates the need for it. So when you log on to virtual outcomes, You'll see there in the little purple box, you've got pharmacy first, and then below it illustrates the types of modules that they're going to be covering. So you just basically have to enter your F code and then select the training that you need. Next slide, please. So we've talked a little bit about promoting the service. David's talked about discussing the service with your GP practices, and I think that's absolutely key. We do know that NHS England is developing or has developed a marketing campaign that's scheduled, we think, to run from around about the 19th of February, something like that. So expect to see an increase in patient awareness and walk-ins significantly from then. I'm sure there will be lots of information at launch, but mid-Feb is when they're really going to start pushing it. We expect the campaign to be very broad. Go and see your pharmacist if you have minor illness, and it'll probably mention the 7 clinical conditions, but we don't expect lots of details about inclusion and exclusion criteria. So again, as David said, your pharmacy teams need to have a little bit of information related to that. And we are aware that organisations like MPA and Newmark actually have some guides that they have developed for counter staff, so that might be a useful point to look for. LPCs are starting to brief local medical commissions. So we've had conversations with the LMCs. We've also been talking to the medicines management teams. We're going to be doing drop-in sessions for general practice, and also talking to the practice managers and things like that. So we're starting to get the message out, but with a message initially of let's take this gradually, and that it's really important that the GP practices speak to their pharmacies before they start sending referrals. Further resources are being developed by Community Pharmacy England to help you to promote the service. So there's a GP briefing guide that you could pass across to your local GP practice. There's prescription bag flyers, and there's also some posters that they've developed that you might want to put up in your pharmacy when you really get going. Okay, next slide, please. Okay, so that's basically the end of the webinar. So thank you for watching. If you've got any questions or queries, then if you send those through to inquiries at Halton St Helens and Knowsley, lpc.org.uk. And also our contact details are always on the bottom of the LPC newsletter, so that you can get them from there. So thank you for watching. Goodbye.
David, can you